Welcome everyone. Today I let me know a little presentation to Kamal. Kamal is a doctoral student in the Department of Alien Health with focus on international public health. He has been involved in dozens of health-related research studies, mostly in Malaysia and Nepal. He has examined HIV, I say prevention, perception, and intervention, and his work considering intersecting factors that can impact the mental and physical health of gay, bisexual, and transgender populations. These factors include drugs use, access to care, healthcare, health literacy, discrimination, financial precarity, and transactional sex, and more. Kamal has also explored the use of apps that would be allow digital health intervention, including social health when people are feeling suicidal. Interesting. In this current project, Kamal has pivoted to focus on mental health challenges in the USA. He's interested in how Latinx population might serve through creative intervention. In particular, he's working with HIV prevention among Latinos who inject drugs. And he also working towards long-term project of using digital platforms to help them manage their mental health. His talk today is last El Instituto series of talks on Latino and Latin American research at UConn. So it's a little mental health among Latinx individuals we use. Please welcome Kamal.
Thank you so much, Luis, and thank you everyone for joining here. Most of my people are from my lab, and so glad that you are here and cheering for me. So, like I received a El Instituto pilot, fellowship grant, and wanted to utilize that grant in a different project, but because of the IIV, I couldn't do that. But what I did was I analyzed the data that we collected that was on mental health challenges among Latinx individuals who use drugs. And we did this in New Haven, Connecticut, with our collaborating partners, Yale University and New Haven City Service Program. So let me begin with the introduction. We see that there is a disproportionate mental health challenges among Latino and Hispanic individuals. During COVID, there 1 in 3 Latino and Hispanic individuals reported depressive symptoms, and also Hispanic adults were 60% less likely to have received mental health treatment compared to non-Hispanic white adults. And this, yeah, and there were barriers at different levels to this, seeking mental health care services. For instance, stigma was one of the major barriers, language barriers, and lack of culturally competence there. And if we talk about other intersecting identities of Latinos when who use drugs, especially opioid, they face significantly higher rates of depression, suicidal ideation, and attempts. And between 20 to 30% of opioid overdose deaths may be suicides that often is mislabeled due to unclear intent. And also suicidal risk factors like hopelessness, financial strain, co-occurring depression are common among people who uses opioid. And there is also a limited study on mental health of Latinx population who use drugs. So what this study wanted to do is to assess the proportion of depressive symptoms among Latinx individuals who use drugs, mostly opioid, and to examine suicidal thoughts and behaviors in this population. Similarly, to explore mental health service use and perceived barriers. And similarly, at last, we also wanted to identify if there are potential opportunities to intervene the problem. So for methodology, we use cross-sectional study, and this was carried out in New Haven City Service Program, which is at New Haven, nearby Yale University. And the participant recruitment was carried out between April and June 2024 through convenient sampling. Our partner organization and collaborators, they were able to help us in supporting the recruitment process. App Foundation, which work for people who use drugs, they were one of our local CVOs who collaborated into the recruitment process. Similarly, in terms of eligibility criteria of participants, the participants were recruited if they were 18 years and above. They self-reported heroin or other opioid drug use in the past 30 days, and also like currently residing in or around Greater New Haven, Connecticut area. So it was a cross-sectional survey. So first what we did was we did the eligibility screening of the participants based on our eligibility criteria. And it was in person. It happened in New Haven Citizen Service Program. The participant, they came in the citizen service program and they were consented and before enrolling, and they it was like interviewer administered questionnaire. If participant were they don't it was like led by our research assistant, and also like they were provided of compensation of like $10 for completing the survey, and the survey was around like 30 minutes, but because we were working with the people who uses drugs and were on drugs, and it usually took a lot of time, to complete one survey. It could have some surveys went up to 2 hours because participants were on drugs during even during the survey. So for measures, we basically look into depressive symptoms. For depressive symptoms, we use PHQ-9 scale. They are it's a scale, and the total score is 27, and 10 and above indicates depressive symptoms. They might have 10 and above indicates depressive symptoms. And 10 and below 10, it's we say it's not depressive symptoms. They don't have depressive symptoms. So for suicidal thoughts and behaviors, we use 3 items from World Mental Health Composite International Diagnostic Interview. It's on suicidal ideation, thought, and planning. It's yes/no questions. And for opioid dependence, we use 8 items: rapid opioid dependence screen, RODS, which is called RODS. So there are 8 items yes/no type, and we assess that to identify if the participants are on opioid dependence. So for data analysis, we used IBM SPSS version 29 for statistical analysis. We have only done very descriptive stats because the sample size is very small, 43 participants. So it is mainly whatever results I'm presenting today is all descriptive. So in terms of results and sociodemographic characteristics, out of 43 participants, the mean age was 44.5 years. 67.4% were male, 30.2% were female, and the remaining 1 participant was transgender. There was many of the participants had completed their high school, but only few had bachelor's degree or higher. In terms of social factors, the 95.3% participants were currently unemployed, and also 65.1% were homeless currently. So in terms of behavioral factors, 67.4% participant use opioid every day, and also 37.2% inject drugs. Similarly, they use majority of the participants, they use fentanyl, heroin, and methadone. And if we look into the overdose in the last 6 months, there was 18%. And the participant currently on opioid use treatment programs were 76.8%. So we calculated the depressive symptoms, and we found that very high, that is 65.1% had depressive symptoms, which is very high compared to other population. In terms of suicidal thoughts and behavior, 41.9% had suicidal ideation. Similarly, 23.3%, which is 10 participants, had suicidal plan, and 27.9% had actually attempted suicide. There was you can see that suicidal ideation 18 people had, but suicidal plan was only 10. But what we can see from here is people might have suicidal ideation and can also attempt suicide without planning. It could be without planning also. So in terms of mental health service utilization in past 6 months, 41.9% visited a mental health professional. Similarly, 30.2% they needed the service, but they did not access them, which clearly show the unmet need of mental health care services here. Similarly, 27.9% believe that they did not need any mental health services. In terms of barriers to accessing mental health care, majority of the participants mentioned that they have lack of information. They were unaware of where or how to seek services. Similarly, there was stigma and discrimination. It was based on because they were people who use drugs, and also at the same time there were participants, transgender participants. They were fear of being judged or mistreated in the healthcare service settings. Similarly, many participants also cited insurance issues because they required referral from provider, which they couldn't obtain. Similarly, there was emotional hesitation, people who, because of anxiety or denial, or their uncertainty about seeking help, and also people who were not motivated or or they prefer coping it alone, so they did not access mental health services. Similarly, there was also some system level gaps because many participants cited that it was very difficult finding culturally competent or available providers. So we also look at the possible interventions because what I and our lab do is a lot of digital interventions. So we thought of exploring if we could also have some digital intervention design for Latinx people who use drugs. So in terms of digital, smartphone digital landscape, what we found was the participants, 72.1% they own smartphones, and 16.3% of users smartwatch wearable devices. Similarly, 76.7% participants can use video conferencing apps like Zoom. Similarly, 67.5% participants mentioned that they can solve basic tech issues. And there was also very high willingness to share personal data from wearable devices. We asked them if they were willing to share their mood-related data, sleep-related data, which are which are the factors associated with depressive symptoms and suicidal thoughts and behavior. So we asked them if they were willing to share mood data. 83.9% participants were willing to share their mood data through wearable devices. Similarly, 84% were also willing to share their sleep-related data through wearable or smartphone devices. Similarly, they were in terms of physical activity, they were a bit concerned, and only 65% participants were willing to share their physical activity-related data through wearable devices to researchers like us. And they had concerns around sharing this data, wearable and smartphone data. Mostly, they have general privacy issues, 34.9%. They say that privacy and confidentiality issues, and 27.9% say that they believe that there is a safety and potential misuse of there could be a potential misuse of their data, and at the same time they were also mentioning that these data are too personal for them. 18.6% mentioned that, and similarly, only 18.6% they had no concerns of sharing any data to researchers like us. So this is my last slide. The key takeaways from this this small scale study, like we see that there is a mental health problem, high depressive symptoms, high suicidal thoughts and behaviors, and at the same time, 65% of our sample were homeless currently, and also like they were active drug users, and people who use drugs. So there's like always like we need to address this intersecting issues, like also at the same time they were unemployed. So these are all intersecting issues that needs to be addressed to minimize or overcome mental health challenges for this population. Similarly, there are a lot of harm reduction services available in the country. There are, sit-in service program. There are methadone clinic. There are other clinics which directly address harm reduction. But there's not integrated. These harm reduction services are not it's not integrated with mental health services. Like for instance, some people who use drugs, they mostly they have our population also had overdose. 18% of them had overdose issues. But the ED emergency department, they don't there's a lack of mental health screening, because there's evidence that overdose, when any people who have overdosed, their next step could be suicide. So if we can early detect or screen them in the OD ED department, or also in the harm reduction sit-in service program sites, methadone clinic, then if we integrate those services, then we can intervene early and screen them early and provide appropriate interventions. So at the same times, there is a willingness on digital interventions, they want to share the data related to sleep, mood, and also physical activity. So there's an opportunity to have implement digital interventions. For instance, we can use wearable devices and we can track their stress level on real time, and also at this stress level on real time, and also provide adaptive interventions to that individual or individual population depicting high stress levels. So that's what that's what we can think about from this study. So yeah, that's all. And at the end, I would like to acknowledge my advisor, Dr. Roman Strester, who provided this opportunity to use this data and present here. Similarly, our collaborator, New Haven Sit-in Service Program, were very instrumental in providing their support for participant recruitment and all other things. Similarly, App Foundation, which is in New Haven, which is also provides support to people who use drugs, and our colleagues from Yale University, Jeff and Frederick Altis. Similarly, Anushka, who was our postgraduate research assistant at Yale University, who collected this data and provided support. Yeah, thank you.
Well, questions, comments? I can start. I know that the sample is small, but what happened relation with the income level? For example, some people have issue with the digital issues. What is the low income or the age? What is the people who has issue related with the digital? It is my first point. The age related with the issue with the digital.
That's a very good question. We wanted to do that analysis, but because of the small sample size, we couldn't do that. But yeah,
I expect my oldest people has issue with the
yes. When we do this digital landscape mapping, we always see that young people they are tech savvy at the same time, and also those who have whose income level is high, or the economic status is good, then socioeconomic status is good, then they have all these like smartphones, wearable devices. But we couldn't measure that here in our study because of the low sample size. We did not do any other regression and other analysis. We just did descriptive one.
Yeah, it's only descriptive.
Yeah,
But we can.
but yeah, definitely I can check
by income, for example. Did you show about the percentage of the use of different types of drugs?
Yes.
What people use specific drugs according to level income, for example.
Oh yeah, that's a good one. But yeah, we haven't done that at the moment. But yeah, definitely we can do that.
My another question is, maybe I lose some point. What about can you explain more about the digital intervention? For example, I use some smartphone.
Okay.
With my smartphone, I collect different information about me. It's only collect information.
Yes.
In what part could be the intervention?
Okay.
Yeah.
That's a very good question. Like what we are recently trying to do focus our work is just in time adaptive intervention. It means like collecting data on real time, like if if my watch is showing stress level is very high, my stress level is high, then like I could get a notification on my mobile saying that your stress level is high. Try this breathing exercise. That kind of intervention can be done through having real time. There are various ways of doing, like for suicidal ideation also. For suicide also there are various ways, like if we see any like stress level, or like use their use their existing data to predict, like we can also predict in advance if like somebody will do suicide, if somebody will have suicidal ideation next day. So what we can do is we can use your real-time data and provide immediate support. For instance, if there is stress level high, then there could be some exercise or techniques that could help you, that through the phone we can provide that immediate support. It could be linked with your app, or it can be also like I know smartwatch. Usually it gives that one like notification, pop-up notification. But what we can do is also like we can provide other supports, like maybe it's very high, then the mobile app, if it should always be linked with mobile app, right? So in mobile app, what it can be is if there is stress level high, you will get like pop-up message saying that your stress level is high. If you want to call your doctor, or like link call doctor, or like support system, then you can call it. So there are various ways of providing like an immediate intervention.
Wow, sounds good. I am thinking in some point, for example, it's you have high stress, un indicator of high stress. One intervention could be mindfulness, practicing mindfulness,
Yes.
do exercise. After that exercise, you can get how much improve or reduce the stress in this moment.
Yes,
It could be.
yeah,
Okay.
that's correct.
Yeah. Good. Another point is related with I am working with many phone data, so I am have issue related with the privacy of the data. It's so difficult because now that people use in your cell phone, you have many apps. And when you install the app, you give access to many information, without read full law terms. So maybe it's important to incorporate, in particular when the intervention is related with the mobile phone. Yes. Because some companies collect the data and doing money with this data. It's so important.
Yeah, definitely. And like for that, like we have existing projects where we have developed our own mobile app. Like for instance, with very high, like men who have sex with men in Malaysia. In Malaysia, it's like homosexuality is criminalized in Malaysia, and there are various like socio-cultural taboos around homosexuality, and also like drugs also. But what we have done is we have built an app, and people are actively using it, and we don't like and we don't have server over there. We have server in another country as well. There is a strict like data protection measures in place. So something similar that we can do for here as well.
Yeah, another before we pass to another, I thinking it's important point. For example, for some people could be work, exercise, or meditation if you use specific drugs. I forget the names of the drugs, but if you use specific drugs, maybe your body have another different reaction compared to another drugs. Maybe mindfully could be work, but another if you use another drug or addictive another drug could be doesn't work. It's thinking for intervention different, maybe different sample, different samples to thinking which work for different drugs.
Yeah, it should be individualized.
Or little samples, sub-samples. I don't maybe extension about this
Yeah,
work.
like these are like some possible things that we also like explore. We also don't know like what we like. There's what we are doing is we are currently also like doing the smart. We have given the smartwatch to the population, people who uses drugs, and we are collecting their real time data at the moment. So let's see how it comes. Then we'll have something like very concrete to plan. But at the moment, we are currently like I think we have just completed collecting data from the smartwatch. The sample is very less. It's I think 10 or 12 people, but still like that will be our like feasibility study.
I see. Well, questions. I have colleagues who is working with
talking to him about predicting for addicts.
Yes.
Like, well, can you go more into that?
Predicting fun.
You could like predict in the future, like you
Yeah.
can smartwatch.
Oh, okay, yeah. We don't know about this, but like what like we haven't worked on this, but we have already started working on suicidal ideation, predicting suicidal ideation. What we can do is we can collect like we can collect their daily data. Like there's a data collection method. It's a longitudinal data collection method called ecological momentary assessment (EMA), where you collect data on real time. Like for instance, what we did was we collected 3 times a day data with men who have sex with men in Nepal, and that questions include like the contextual factors like social support, smoking behaviors, their sleep and all. They report on real time, right? So that data will help us to like using machine learning. I know it's a bit complicated, but using machine learning, what we can do is we can using those data we can predict if that person will like will have suicidal ideation next year or not. It will be through machine learning. So there will be like different predictors will be used to calculate or like to predict the next day suicidal ideation. Similar to that, I think we can also do for our people who uses drugs. So we have not explored that, but there is a possibility and people have done it before.
Well, so what's the next step for you? I think the results you shared are very important. Like also Luis mentioned, right? Particularly around the complexity of issues that are there, and also the opportunities, especially around digital health intervention and how that platform could be utilized for intervention development. So, what's your next step?
Yeah, that's a pretty good one. But as I mentioned earlier, like we have recently doing this feasibility study, like giving people the smartwatch. We have we gave it was Garmin was and collecting their real time data. We haven't analyzed that data. We have captured their sleep, stress level. I think the physical activity related data, heart rate and all, everything we have collected. Maybe like we can use those data and see if we can also like try to link it with just-in-time adaptive intervention, which is like giving. Sorry about that. It's too technical, but it's like giving people intervention on real time, and it is not. It is individualized. Like people will have the intervention based on their needs. So maybe that data, like next step could be like if using both sensor data and also like EMA, ecological momentary data, because like the population is very people who use drugs, it's very difficult to like get the EMA data. Because we tried, but like I think we also did ecological momentary assessment with them, but I don't think the evidence is that good. But like if they have watts on their hand, I think we can measure many like many variables that could be the predictors of depressive symptoms and mental health. So using that, we can also try to think of just developing just-in-time adaptive interventions for them. But in case here, in this case here, we need to like integrate smartwatches. EMA, I don't think it will work that much. That's my that's based on the current formative work that we are doing. But definitely, smartwatch could be one way to like have real-time data.
I think it's so important point. Maybe you can thinking about some collaboration with engineers to create a specific app.
Yes.
To collect, for example, when the people use specific drugs, the app could be react specific drugs. I don't know, you app, are you working in a new app now or is for future?
Yes, what we are doing is like we are also very new to this area. What we have done is we have already started working on suicide prevention for Nepal. We have we have already collected EMA data, and we knew that those EMA data can predict next suicidal ideation. The accuracy was like more than 85% through machine learning. So we know that like it's working. So what we are trying to do is we are trying to build an app for Nepal at the moment, and see like if we can bring that learning to this context. But I'm not from tech background. I'm from like health promotion. So we work with different technical team who can do that, and we have like existing collaborators who are already doing that kind of.
Yeah, I think it's important because the percentage of the population who use drugs and depression is high. So
Very high.
you need thinking which tools we can use to avoid future.
Yeah.
issues, no?
Even like the research is very limited on like people.
Yeah, it's a
using
sample.
drugs. And I couldn't find any like very few literature directly looking at the mental health of Latinx people who uses drugs. So yeah,
Maybe another extension could be implement run some pilot study with more sample to collect more and more data if the data could be external validation.
Yeah, that's a good one. And at the same time, the simple intervention could be like because these people population go to resident service programs, a methadone clinic, and also like many have overdose and they usually visit ED department. So that means like if we have like some like the mental health screening services or mental health, like just like some basic services over there, I think that will be a big point because like we could like screen them and provide immediate support. I know like that could be like the real solution at this point. Later, what we can do is we can just link that mobile app to those clinics, like if they have anything related, if they want like if they want to speak with counselor, maybe they can do video call through mobile app to that clinic. So yeah.
Adding on to the emergency departments, I know you said that a lot of them don't focus on the mental health aspect of like drug use and like going through that clinical. So like is that due to training that they don't focus on it, or like resources, or is it just like because it's geared toward the physical rather than the mental?
I think it's not about security or anything like that. It's like how the the health system works. Like if it's overdose, they will only look at the overdose. They don't look at all the aspects. And there's a research that like overdose is, I think it's linked later. I think it's linked with suicide, like people with opioid overdose, they usually like if they have overdose, but there's a high chance they will also be attempting suicide. So there is existing evidence on that, but still
It's like just the system
Yeah.
and then how to.
I also don't know. I think it's maybe the system. They don't have this screening services in place. So
Thank you for this presentation. Unfortunately, I missed the first part, but what I have seen so far is very interesting. I would like to ask you if you have considered put this information in dialogue with other qualitative-based research approaches. I tell you this because we are working in a harm reduction service in Bridgeport, in which we are working with different population of people with drugs, but our focus has been on Latin American people with mostly alcohol, but other substances as well. As a team, we are doing an ethnographic approach to understand the motivation, why people is in that situation, and the different aspects about people who use drugs, which involve lack of employment, lack of housing, different things that motivate migrational trauma and other traumas. So it's for us could be interesting to put this information in the location something like this.
Definitely.
That gives us a more comprehensive.
Yeah.
approach.
That's a very good solution, because like here in the United States, this is our first study on mental health. We were focusing entirely on HIV prevention, and while doing HIV prevention, we thought like putting some mental health related question, and the statistic told us that it's very alarming. This is our very first study. So next step would be like when designing intervention, yes, ethnographic or doing qualitative study with this population would be very helpful to have very tailored interventions to this population.
Thank you. Well, thank you very much again.
Thank you.